All right, good morning. It is Thursday, March 13th. Tomorrow is Pi Day. Hey, so that means everybody has pizza. No, my son-in-law's birthday is tomorrow, so they always celebrate with car. All right, so that makes you feel better. Pi Day. So good morning, everyone. We've asked the NEA and the VSEA to come in with their proposal that they mentioned yesterday. And Jeff, do you want to just tell us what is in that proposal briefly?
Sure, I'll try to do my best here. On the record, Jeff Fannin, Executive Director of Vermont NEA. I know Colin was here yesterday and try to explain this a little bit, and I'll do my best to back up his work. So the concept here is reference-based pricing is set a reference of base level and go from there. In this case, the proposal is bill charges at 200% of Medicare for 6 hospitals only, so not the critical access care hospitals. So it segregates out certain hospitals, I think the concept is the Green Mountain Care Board would also then try to ensure that there's no what I would call balance billing to private payers and the concept, and so there's no shifting the cost shift that's always talked about in healthcare. So that's the concept in large. I don't know if there are specific questions about.
That's good. We haven't seen the language. I mean, we don't have the specific language before us. I know you sent us all the.
Oh, it's on your website from yesterday.
Yeah, we have that.
Okay.
We don't have specific language. So, okay, so that's helpful. And the 200, I did see also in there was a 200 and a 300. I'm trying to figure out if it's only 200% of,
I don't recall
Medicare.
300.
Okay, all right. So I must have looked at it earlier or something. Okay.
I didn't see that.
And then there's no balance billing, so it would, and the 5 hospitals are.
The 6 larger ones, as I understand it, and
so Rutland,
UVM. Don't hold me to this, but Northwestern probably. I don't recall.
Okay, they're in the right. Okay.
Yeah.
Okay. Questions committee. All right, so we'll come back to this and have a discussion. I just want to share with you that, and we'll ask the hospitals, and I've heard from others about the effect that this may have. So we'll be able to share that information.
Yes, okay. Happy to stick around. That's what I'm here.
Yeah, I don't know when we'll get to it. We might get to it right now. Okay. We're good. Thank you. All right. So, Devin, I know you had a comment on this and had looked at it. Do you want to make?
Yeah, I'm happy to speak to it.
I also heard from Sue Siglowski relative to VHA on this. So, and I'll get Kiki to put through VHA as well.
So Devin Green, Vermont Association of Hospitals and Health Systems, and I did just want to refer to the report that the Green Mountain Care Board did on this back in December. And the finding that they had was this would basically be a $79 million cut to hospitals statewide. And just to remind folks, the actuals came out yesterday. Our total hospital operating statewide margin is $54 to $55 million. So more than our operating margin. Now that's statewide, and this proposal carves out critical access hospitals. And carving out the critical access hospitals, it would still be a $62 million cut to hospitals. That is a very large cut. The impact, the report did not, it was required in the budget language to go into the impacts to the exchange plans and to hospital margins. It did not address that. So there's not enough analysis done here. And the report also said more analysis is needed in this.
Okay. Got it.
One other thing, other states, this has been 1% of the population that it's impacted. When they've done reference-based pricing, this would be 9% of Vermont's population. If we're looking at all state employees. Again, we don't have any of the analysis about how it impacts PPS hospitals versus critical access hospitals, but it is a really big and sudden change that would have big impacts to care.
Okay, thank you for that. I know one of the concerns that we had as we've been writing the bill is to implement reference-based pricing on over a 3-year period so that we buffer the rapid decline in revenue. So we forget that.
Yeah, and I think that was the global budgets that you're doing 3 years. Reference-based
Yeah, we got it.
sooner than that.
We're good. Okay. And did you put Sue Sablowski's? Oh, say it's up on our webpage. You can look at it. This came to us day before yesterday. We heard about it yesterday. We heard about it today, and we'll be talking about it as we go through the bill. So, Jen,
Yes.
we want to make hay while the sun shines. You like that? Yeah.
Good morning. Good morning. Jen Cardy from the Office of Legislative Counsel. So how do you want to proceed?
So if everyone has their hard copy of the bill, I think that might be the wisest thing to have in front of you. The committee bill. Our committee bill. What other bill is there? Oh, the committee bill. And then what we'll do, Jen is gonna walk us through. We did spend time last evening going through testimony, all the testimony that we had, and trying to identify places where we would have decision points. Jen's gonna lead us through.
Yes, do you want me to put the
We're gonna
language?
add our thoughts, and we'll try, here's the goal, as much as possible to resolve the questions, as many of the questions that we have, that we can. And also knowing that we still have to hear testimony from AHS this morning. So go ahead.
Do you want me to put language up on the screen or? do you want me to
Yes,
just?
that would be good. And then we'll know where we are. We got it.
Yeah. I didn't have files on that, so I'm not on Zoom yet. I'm joining now. Because I picked the wrong one. My brain is already on Friday, so I tried to join Friday soon. Okay, now it's- All right, here is the version we have been looking at, draft 1.3. And the bill, at least in its current form, starts with the sections on hospital budgets and payment reform. Madam Chair, I don't know if you had thoughts on adding something before that to kind of set the stage in the bill.
Yeah, so as you recall, I read through some of the goals that we have embedded in the bill. I thought what I might do is I'll write those out and have Jen sort of put them together in a form that we can look at and then decide what we want to keep and what we want to throw out. We like the title of the bill. That's another thing to think about, and that's the last thing to think about. And don't worry, come back.
Yes.
It strives to be in.
Objective plain language description of the bill.
Yeah. Bill
Few
words.
All right, so the first section then is on the duties of the Green Mountain Care Board. Starts off with a lot of existing statutory language, but adding in some references to reference-based pricing. And including in number 5, the existing list of duties is to set rates for healthcare professionals to be implemented over time, and Bill added beginning with reference-based pricing in 2025. I think the Green Mountain Care Board had suggested changing that date certain to something a little more flexible, like as soon as practicable.
No later than 2027, right? I think we should leave it open
And
otherwise.
the chair wanted to put a not later than date. That's how I feel about.
If you're okay, if you let us know if you want to put that date in or not.
So, right, so are people comfortable with changing from 2025 to as soon as practicable? And do you want a, but not later than date? And if so is 2027.
I'm absolutely fine with the practical, like, for just practical, but I'm okay with that.
Okay.
That's what I'm looking for.
So with you.
Okay.
Just, it may not be practical.
Practical.
For 10 years.
Right. And we don't know what that means.
Yeah.
Okay.
Okay. I don't think you heard anything about number 6 here, which is just taking into consideration changes in payment method and amounts, including implementation of reference-based pricing and the health insurance rate review.
Is this where we were going to say something about, moving toward capitation or global budgeting?
This is really, I mean, this is
Not-
describing their
just-
duty
okay.
to approve, modify, or disapprove health insurance rate requests.
Okay,
So I think this is not where I would put a lot of
that stuff.
heavy hitting policy stuff. I would put that more in its own provision. Then we have, again, an existing duty to review and establish hospital budgets. And there's a lot of new language here around establishing standards for global hospital budgets that reflect implementation of reference-based pricing and the total cost of care targets set by the statewide healthcare delivery plan. And that beginning in hospital fiscal year 2028, the board would establish global hospital budgets for not fewer than 5 Vermont hospitals that are not critical access hospitals. And by hospital fiscal year 2030, the board would establish global hospital budgets for all Vermont hospitals. So a couple things I think we've heard here. One is just anywhere throughout the bill that there's a reference to the statewide healthcare delivery plan, I'm just going to be adding once established. There's a concern about aligning with something that doesn't exist, which is fair. I would argue you don't have to align with it until it exists, but I think recognizing that duty exists once it's established is fine. So I'm planning to add that phrase once established throughout.
We talked about that a lot.
So the other piece is that my notes say the Green Mountain Care Board wanted these global hospital budgets or the total cost of care targets to align with the total cost of care targets in head.
Yes,
Is that?
yes.
Oh,
Yeah.
I think the timeline, the 28 and 2030, should align with the event.
Yeah. Right. Yeah, we should do that.
Okay, and I will look at what I have from the board, to see if I have language or need to get some language from them about how they'd like that phrased.
There's another question about beginning with an individual hospital. Is that, or is that not? I know the board had mentioned that at some point.
Oh, they may have that. I don't have that.
that.
Okay,
Isolate.
let me pull out the board's notes. Yes, so actually what the board had
Maybe we can.
had sent along in their comments is to consider adding this flexibility,
Okay.
consider adding flexibility for the board to pursue global payments in addition to global budgets, which is a defined term, global payments, and also they note that the head model agreement requires 10% of Medicare fee-for-service net patient revenue to be in a Medicare hospital global budget by 2027, and requires the state to ensure at least one Vermont commercial payer offers a commercial hospital global budget by the start of 2028. not entirely sure how to incorporate that in there, but hopefully they have thoughts on how budget.
I apologize. I was on my way here a half hour ago and I've spent the last half hour being yelled at. A constituent who would not get off the telephone. Sorry. So I'm here.
We're glad you're here.
Is your blood pressure okay?
I'm not sure. I've got two different ears. They're my talk.
We're on page 3 and you can just relax. We're glad you're here.
Take a deep breath.
We're going through the bill.
I'm
We've
not
looked at-
turning Vermont into Georgia. I promised. I'm so glad I'm today's over.
Okay, so the board had recommended some additional flexibilities, and I don't know if those align.
I'm sorry, go ahead.
Okay, the board had added some additional suggestions about global payments and about giving them some flexibility. We don't know if I have language from them on what that would look like. Do I have language from them about that?
Excuse me, sorry, for the record, Diane Larry, Green Mountain Care Board. Is it okay to speak, Madam Chair?
Yeah, please.
We did have some feedback after our testimony yesterday from our legal team. They did make some suggestions. This particular circle, I don't see.
Is it this, these,
Flexibility to alter global budget implementation timeline as necessary to comply with the head. We have that part, but I think they made it consider flexibility, like the village council said, global payments in addition to global budgets as defined in 18 VSA 9373. So I think I can't speak for exactly their motive, but I can say it looks like they're trying to align the definitions.
right, so this, that you're reading from this,
yes.
that they sent us.
Yeah.
We should have this on our webpage as well.
I believe it was posted yesterday.
Good, so we'll use this also as a guide going through. Okay,
Yes.
good. So so Jen, unless I hear differently from you, regarding the reference. Statutory reference, I probably should go ahead with that.
No, if you look at the definitions, but I assume if they say it's a defined term, that's in their chapter.
Yeah,
So I will add additional report, which.
Yeah, notes, I'm not sure if I have here. It's on this page. Say, make sure that everything coordinates with the head.
Right, that's.
yeah, we got it.
Before you got here.
We did it.
Okay, and I think that's a lot of what they're talking about in more specifics here is that alignment ahead. Okay,
That's number 7. Now, Sam, you want to make a comment?
Yeah, so Green Mountain Care Board yesterday, I can't remember if it was David or Owen, one of them said that there should be like some sort of guardrails to know, is this helping, is this working, like as they're going, as
That's why I don't know.
forward. Yeah, so I thought maybe have a check back report from Green Mountain Care Board every 2 years or something like that. Just, is this working, is this helping? Are there any pitfalls you see? Is there tweaks that need to happen?
And I remember the hospital saying,
Yeah.
how do we know it's not working? Because
Cool, yeah,
we're not sure going to reference-based pricing, what it's going to do to the hospital budgets and how do we know when maybe we need to pull back or do something else before the
moving
hospital?
too fast, too slow, all
Yeah.
of the above. Jen,
Yeah.
where's the best place to put that kind of check back?
I think we'd want to do it as a standalone report later in the bill and not codify it.
Okay,
Because this is really, again, this is a list of the duties of the Green Mountain Care Board.
Going off of what Senator Cups was just saying, would it be reasonable to have VAWS and hospitals also weigh in on a report like that or a separate report, just to get their perspective as well, if you're not careful?
so hold that thought. And as we go through the bill, we'll pick up other places where we want to have effect back or information. And then we can, the board may be working with stakeholders or however it's going to be worded.
And perhaps somewhere in here, we should say this should be done, but they should also sure they're gonna do it, whether or not we tell them to. Also be monitoring the financial health of the hospitals to make sure, is it a goal to keep the hospitals afloat?
That's the
Right, I
point.
think that's part of their ongoing,
Yeah,
that's-
okay.
Yeah, you got it.
but I think we could do some sort of an implementation report. I mean, I do think to the extent that things are not going well based on language that you passed, you tend to hear from the affected parties,
Right,
without without requiring reporting.
and then as we're going through that, let's keep going, but we'll come back to that as a standalone section, and whether it's a full written report, whether it's a presentation, because then sometimes it's helpful. You can have a more frequent report if it's a presentation, and if you get a report, then it's a lot. That'd be good.
Right, you can have them provide updates during
Updates,
during legislative sessions.
Good idea.
Yes,
They take a long
when
time.
you say update, you give them some flexibility in what format it comes in. Is
Yeah,
it a
A, B, C,
report?
D is just fine.
Is it a memo? Is it a PowerPoint?
Doesn't have to be 50 pages long.
Okay.
Okay, so now we are on to section 2, which doesn't have a lot of changes, legislative changes for a while, but this is the existing statutory section on payment amounts and rates, and really the Green Board rate setting authority. It is structured in the existing law as setting rates for healthcare professionals and others, in order to have consistent reimbursement amounts accepted by them, as opposed to setting rates that the payers would pay. It sets rates that the providers would accept, which may give us more flexibility on which payers can be involved. But in at least as currently drafted, the reference-based pricing provision is more on the payer side. And one thing that the chair and I have talked about, because I know you've heard a lot about commercial, making sure we're specifying commercial insurers.
Yeah.
And I thought we might want to add, to the extent permitted by the federal law, third-party administrators of self-funded plans. And that includes then some of the groups you've been talking about, like the state employees and teachers, because they're governmental plans that were not preempted under ERISA's regulating. So instead of payers, I agree, you've heard a lot of testimony that we need to be more specific about payers. I think that's a fair point. So I would suggest something along the lines of reference-based prices that represent the amounts that health insurers and, to the extent permitted by federal law, third-party administrators of self-funded plans shall pay to healthcare professionals for services delivered to Vermont residents. You also heard about not limiting it to services delivered to Vermont residents. And so I think that's, I think you could take that out and you could just say services delivered in Vermont. I know we heard that Oregon had reference-based pricing language in its statute. I did look up the statute while we were taking testimony yesterday. I'm not sure how helpful it is. But we can certainly look at it, or I may have some recommendations from the board. So kind of keep looking at it. The board recommends changing the framing of reference-based pricing and provider regulation, which is what the way the rest of this section is phrased. I think we could do that. They say exactly what I was just saying, that while Oregon framed its law as payer regulation, government plans are exempted from ERISA. That's the piece I was saying about the federal law and third party administrators. They want to also expand the scope of reference-based pricing to include items or supplies, which is Medicare terminology. No, items of Medicare terminology and supplies, they say it's Oregon law, in addition to services. Probably makes sense. I don't think that we were thinking solely services. Like that's of services. That would be line 16 is where it says services.
So we're changing it to,
Well, do you like items or supplies? I think items is probably. Clearer if it's a Medicare term.
So, yeah. Oh, I'm happy to finish for that section. I want to go back up to the top briefly.
And when I don't have a conceptual problem with changing it to regulating providers rather than payers, but I really need to think about what that looks like from a drafting standpoint.
Okay.
Because as they said, Oregon framed its law as payer regulation as well. I don't think it should be terribly difficult if that's the lens you would like to do it with, because that is consistent with what we do in the rest of this existing section. But you're kind of up to the committee. And the question is really, do we try to align it with what Oregon's law looks like, or do we put it from a provider lens, which is the way the rest of the existing section is structured? I think, it's probably a question for the board of what is easier for implementation.
Is there anywhere?
They're suggesting provider.
Yeah.
Maybe provider is easier for implementation.
Okay, right. Got it. Go ahead.
so we are changing the provider.
Well, I'm making a note to potentially reframe it as provider, and we'll talk to the board about what that looks like. Comments for you. So on page 6, from the bottom of page 5 onto page 6 has the board consulting with payers, including health insurers and the Agency of Human Services, on ways to approach reference-based pricing. I think you've heard from hospitals and others that they would like to be consulted as well in the development of those. So I thought we could strike the reference to payers and just say, board shall consult with hospitals, other healthcare professionals as applicable, if there is expansion beyond hospitals, and to the extent they have relevant input, and then include insurers and the Agency of Human Services as well. Is that
Good.
work for folks? Yeah. Okay. And then I think I had a note to myself here. There was language from Buzz about
Was on page 6 of Buzz.
That was 6 because it's different.
I got it.
This is the one, I think this was the part at the top of the second page of Buzz's testimony. I think we have some other language from other sources as well, but getting into this idea of taking into account payer mix, acuity,
Right.
social risk.
Yes. Yeah, that was good.
And setting that.
Yeah.
And setting the reference-based prices. So I was looking at adding a sentence like that for you to look at. You had, again, appropriate feedback from folks that there needs to be some sort of benchmark for services that Medicare does not cover. I'm not sure what that looks like, but I think and maybe it's just giving the board flexibility to identify an alternate benchmark for services not covered by Medicare. And
That's
that
right.
say that they don't.
Pediatrics.
Exactly.
Right, because
They
it's for
do.
disabled.
Well, I
people.
wondered about that too.
Yeah.
Yeah, so they may, I don't know if there are things in Medicare that they don't, but I
Well,
wonder.
yeah,
about
because
that.
there's
Because there are
also
people
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 with
eye, so they may have.
Right, you can have
yeah,
younger people with
Right.
disabilities who receive Medicare coverage.
Yeah.
They may have. So I don't know how much we need to reference it or not. I don't know enough about the Medicare code set to know if there are services.
Or similar.
Right, the board is suggesting expanding. I guess we're pretty much there, from, lines 4 and 5 from. Based on a percentage of the Medicare reimbursement rate for the same service, they said, or similar service. And they cite to Oregon's law that says hospital service or supply that is covered by or is similar to a service or supply that is covered by the Medicare program. I don't know if you're comfortable with at least saying the same or similar service. Probably makes sense to give flexibility.
Yeah.
And may not be over.
Yeah. They're not all gonna be identical.
Why don't just trying to look at everybody's.
I was having notes here on section, on number 2 there.
Great.
I think in the Green Mountain Care Board, they mentioned coverage under reference-based pricing to differ from service to service. They have different, I think having different for different services, I think that's what they're talking about.
I don't know if they would have a different benchmark or if they might set a different percentage of Medicare. I don't know.
Let's see what they say. This is when we're learning when we go. As we go. We don't know what that percentage needs to be. We're leaving it up to them to.
Yeah, they need some flexibility.
VMS, Vermont Medical Society had suggested language in, sort of second lines around line 7 through 11 about. I had language in here giving the board the option to have a reasonable rate of growth separate from Medicare rates, just because we don't know what will happen with those rates at the federal level. And Jessa had suggested indexing them to the Medicare Economic Index measure of inflation. I don't know what people's thoughts are on that. It's not a benchmark I'm familiar with. And it could be something that we give as an example, but don't.
That's
Don't
or
lock.
similar, yeah,
Similar.
I'm not familiar with, which is just because it doesn't come up for me, but
You said that's the benchmark of inflation.
it is the Medicare Economic Index measure of inflation. It's in Jess's testimony from yesterday. And so I'm thinking maybe you add it as a such as, but continue to give the board flexibility. Okay.
I like the subject. There was we do have comments in the bill on avoiding balance bill. Is this a place to have that? It's a recommendation here from the board.
Yes, I think so. I want to think about whether it belongs. It probably makes sense to include it in this part while we're talking about.
Yeah.
Yes. Okay, I think that's all we have for that section, but it would be helpful to know from people who work in the Medicare world, whether there are services that do not have Medicare rates because they're not Medicare covered, which I
Right.
imagine there are some long-term care. Although
Pediatric care.
but we're talking about reference.
Monica Ogilvy is behind you. maybe.
Yeah, okay.
Yeah, so, yeah, there are some.
Okay.
Small, non-hospital services.
Okay. All right.
That's a big one.
Right. Right.
We're not sure if it's a hospital service or not.
Right, so I think we're starting with hospital services, but, I think that's a good point. All right, so then we have in number 3, the board beginning reference-based pricing by establishing the amounts that, and we're gonna, again, figure out here if we're dealing with providers or specifically says health insurers and health insurance plans. But I think you're talking about going broader than that to the extent we can, and maybe looking at it more from the provider side. So that needs attention. And then the date, we have in here hospital fiscal year 2026. You've heard from the board, they would like as soon as practicable. And I think again, the chair suggested, but not later than hospital fiscal year 2027, which begins in October of 26 and goes into September of 27.
I'm not sure that's,
Not sure what.
well, as soon as practical, I have no reason to believe they don't want to do that as soon as they can. I just don't want to be back here next year being told, this is a lot more complicated than we thought it was going to be, and we don't know if we can do it.
So this is why you put in, no later than 27, but then we're also, as we get to the end of the bill, looking at the resources needed to accomplish the goals. So you're right. I mean, we don't know the future of this at all, but it should.
Not more than ever.
Yeah.
You did put in language in the sort of description under the board's duties of as soon as practicable, but not later than 2027.
Thank you, Madam Chair, Diane Lambert, Green Mountain Care Board. Because there's so many unknowns floating around both this bill and many other things, and the work that I think there's well-intended direction that everyone wants to paddle in, that as soon as practicable, you could hold our feet to the fire as it is your duty to do so. If it's not as soon as you'd like it, or we could report as to the progress on it. But by putting in a firm deadline, which is not a bad idea sometimes, I would be concerned that we would have to divert all kinds of resources to
We hear you. I mean, we
Okay,
heard
good.
that in the testimony,
but
we hear that. Our goal is to, we
Make
wanted
sure.
to start this in 25. Now we've moved it out and we said, 26, now it's 27. So, as soon as practicable, no later than 27, but, you know, life is not always fixed in time, so we'll come back there, I'm sure.
well,
But we hear you. We do understand.
and we won't be gone in
No,
25.
it's the issue around resources and the time
Mhm.
that a human being has to accomplish work. We get it.
Thank you for
They may
your.
not get them.
Yeah.
I can be budget. Because Diane understands that.
Okay. And then number 4, which is the reference-based pricing for non-hospital services. You've heard various testimony on this. The Green Mountain Care Board does not support it. They say numerous non-hospital services do not have a Medicare price for benchmarking. I think you're talking about consider narrowing to just non-hospital primary care.
Yeah, did we said to make this AHS
Yeah.
consultation.
Right, so you and I talked about
That was
maybe
possible.
AHS in consultation with the board for non-hospital services. Non-hospital services are not really board's bandwidth as much.
Is it something that can be taken out for the bill?
Can we just can we strike this part?
Right.
You could make it a may,
Yeah, we could make a controversy.
Right?
you could make it a
We'll hear
may,
from agents.
Okay.
you could make it, and I think there was some confusion, but again, I think it's legitimate around what is meant by non-hospital services. Are these any services performed outside a hospital? Are these services that hospitals do not perform? Is it both? So I think it would be good to figure out what,
Community-based
want.
services.
but I think, I was thinking perhaps of saying for services provided outside a hospital, such as primary care. Recognizing some,
Yeah.
there may be some primary care that is provided in a hospital setting for various reasons, but
That include things like physical therapy.
Yes, good.
I mean, how broad is that?
well, it's a may,
It's a may.
or we just talked about it. Yeah. Um, So, and it does reflect that it could be another benchmark as appropriate, so, so I feel better about that. And it says first to enhance access to primary care and later for alignment with the statewide healthcare delivery plan. I don't know if that's language that you want, or if you want to modify that in any way. We'll check it out.
We keep the section, because you keep trying to do alignment.
Yeah. That's just,
The board asked to take out number 5, the board may enter into contracts as needed. I think their concern is valid, that if we say it here and we don't say it other places in law, it does call into question their ability to contract without specific legislation, which I don't think.
But I don't have that, they already have.
Yeah, exactly. They already have that ability. We've given them resources, so, okay, so I think it makes sense.
yeah, go ahead. Who wants to go first?
So are we striking 5?
Straight back.
You strike it.
I was just fine.
Yeah.
I like board.
Me too.
We'll strike it. So there was an issue.
1.5 full cents.
Yes,
Yay.
progress.
There was something that, I did want to bring up, and I'll mention now so I don't forget it, because you'll remember it for me, and that is that in order to evaluate hospital budgets and, reference-based pricing, one of the things that needs to be transparent are the contracts between hospitals and payers. So somewhere in here, we might want to say something about allowing for the board to see those contract or DFR and the board to see those contracts, because they don't kind of know what the numbers are. Somewhere, I think, I don't know where it goes, Jim, but I have forgotten to bring that up.
Yeah, I know we looked at that concept in past bienniums.
Yeah, we have.
So I don't know, maybe I'll just, at least for your next draft, dust off that language.
Okay.
Put it in here. We could look
We
at it.
can look at it.
You could pare it down. I'll look at a pared down version.
Okay.
And I think we would probably put that. Think about where people want to put that before we leave these group of sections that deal with hospital budgets and payment.
Sure, yeah. We're going back.
Easy restriction.
We'll all be sitting next to you.
Okay, so section 3 is hospital duties and what information they have to file as part of their budget review process. The board says to consider incorporating hospital filing duties with elements of hospital budget review. In the next section, I don't disagree, but I'm not sure that's a project I want to take on at this moment of the crossover week. So if they have specific suggestions, I'm happy to look at them. Otherwise, maybe that's something we can look at in the future.
There were, I think, here, I'm looking at the latest table that we got, it said incorporating hospital filing.
Right. That's what
Yeah.
that's what I'm saying. I'm not,
Yeah, okay.
I think it's fine to consider that. I would prefer you to not consider that right now.
Okay, well, we can do that.
While you're trying to do
We can do that.
all of this, reform.
Right.
Okay. My ability to do that between now and tomorrow is going to compromise some of the rest of the work on Bill. All right, so the provisions around reporting the number of employees whose duties are primarily administrative and those primarily involving direct care delivery and base salary and total compensation information for executive and clinical leadership and direct care providers. The board supports, a lot of the other entities do not.
There was a comment on the uniform system of accounts and that.
Yeah, I'm not there yet.
I got it. Okay,
Let's
sorry.
focus, okay, let's just focus on
Number 8.
I'm not.
focus on 7 and 8.
Got it.
So I think you heard from the board, from FOS that they do not support this, that the board already considers salaries. So I don't know if the extent to which this is strictly necessary. I have been trying to kind of parallel the reporting or providing information section with the board review section. The board supports it, FOS does not.
Well, leave it in for now and then see.
Uniform system of accounts, I think that, we heard that the language was not quite right, which is fine.
Is this for a desk?
Yes.
Yes, this is the adaptive piece.
Yeah.
The board's testimony says consider appropriating funds to the board to hire a consultant to review each hospital's accounting system and define uniform line item expense breakouts that each hospital could report on. You heard. It felt a little different from what I thought you heard yesterday.
Very much, yeah. We heard that they already have an adaptive and that it would be the hospitals providing the financial information that fits with their financial.
Right, so Voss suggests just saying that the board build up its current capabilities for hospital budget data standardization.
Talking, I'm sorry, Diane Lake Chart of Accounts.
Yes.
Talking? Okay, yeah. Yeah. I think we heard yesterday from our hospital services financing team that they do a lot of this. This is where I think you heard Matt speaking about the alternative method instead of having to have the hospitals go through all of this unified chart of accounts and changing. There was a way to get at a lot of it by having Green Mountain Care Board have the ability to hire a consultant to help us with matching what they send in with the alternative chart.
And so let me ask you this, is that a one-time consultant to help that happen?
I have a note here that it's one time, but
Okay.
I see what
I
happens.
mean, that would fit in with the resources needed at the end. So,
It would be, yeah, because we could hire a consultant would be
right,
within.
so I don't know how to say that here, but you want that there would be, that the board would align adaptive or hospital
I think we
financial
can-
information with adaptive something.
We may be able to use some version of Devin's language about hospital budget data standardization. Just have have hospitals submit information as directed by the board to maximize hospital budget data standardization.
Okay.
And then have something in session law that, you know, directs the board to hire a consultant to figure that out.
I think we need to remember when we tell hospitals to do something that involves time, which is money.
We don't have it.
Yeah, so this little extra that we can demand, I think, better would be to everybody's body. Great.
Okay.
It's resources.
Get it on the train. Get it on the train.
Get it on the train.
I'm getting on the train.
Oh.
Beef wax olive oil.
Let's get on.
What's what is
It's made in my district too.
So we are ready to move on to another section, but I see that it is basically time for, I think, when you want to do the from AHS stuff, so it's.
Yeah, let's go to AHS. We're a
Good
good
place
place.
to stop for now.
Where are we ending? Let's see, we're ending at
Ended at the top of page, we're gonna start up again at the top of page 8.
perfect place to stop. So we're at page 8. And
Where do we find that? So where do we find that?
I get it online, but it's my district.
No questions asked.
all right, so when you get to markup, you want to just keep going. So we're gonna move on to AHS is here. And Monica, are you or Jenny here?
Oh, yeah, yes, thank you.
Okay.
Just thinking about space. Yeah. She probably wants to.
Yeah. I've got headed within.
I know. Amazing. Wanna come with the hot seat? I want you and you.
So let's, we need to close the door. We're doing a count on the number of people. How are we?
18, so we're technically 2 over the max limit for COVID revenue measures.
Okay.
And it is the 5th anniversary. I'm gonna make recommendations.
Right, yes. I have it on my calendar with the police dog. Calendar given. I just put off one.
Will start.
Time flies when you're having fun.
Yeah.
Okay, so,
Well,
Thank you for having us.
and we have your testimony,
You should have our testimony.
so we're half
For the
paper
record,
and we're half online, so thank you.
for the record, Monica Ogilvy, State Medicaid Director and for the Executive Leadership Team at the Agency of Human Services. Thank you for having us today. We brought in a handful of members from our agency to speak to different sections based on their area of expertise. So given the popularity of this topic and seating in the room, we'll move around a bit and have people swap in and swap out if that's okay with the committee.
Any way you want to do it, I mean, and just knowing what our time is worth it. Appreciate that.
And I understand that we now have a compressed amount of time till 10:15. Is that correct?
Yep.
You got it. We can make that happen. So thank you for having us. Overall, we are very supportive of the direction of this bill. Agree that some coordinated effort and planning should be going into this. And we have been doing quite a bit of this together with our partners and colleagues inside and outside of the agency, and are happy to continue doing so. I think some of our overall points that we just wanted to make sure that the committee understood as we approach this work was number one, that AHS maintain authority over all things related to the Medicaid program. This is inclusive of rate setting, payment reform efforts, and hospital global budgets. it would be unprecedented for that to change. And we don't hear any testimony in otherwise, but certainly just wanted to make sure that that was abundantly clear, given in some of the sections, there's very broad authority given to the Green Mountain Care Board over certain activities. And so just wanted to create some very clear expectations and boundaries right out of the gate. We also wanted to make sure that much of this authority that we're talking about, Green Mountain Care Board, focuses on hospitals and should not exclude non-hospital services. Similar to the conversation we were having earlier this morning, there are many hospital services out there that are almost all solely covered through Medicaid. Thus, we wouldn't have Medicare to reference prices or rates. And so we should be really thoughtful about expectations as we engage the agency community services and Green Mountain Care Board in this work together. Just so we have clear, again, expectations and boundaries for each organization's role in this work. In a similar vein, thinking about commercial rates, we wanted to just ensure that Green Mountain Care Board's authority over rate setting and payment reform would be specific to commercial payers, again, just the Medicaid boundaries. And lastly, we really want to be cognizant about system alignment here. There are a lot of different models and changes being contemplated within the system already. And we have heard a lot from our hospitals and from our healthcare partners that having alignment really makes their jobs easier and less burdensome. Certainly, we don't want to create more work for them than necessary. So when we contemplate things like timing and changes and deadlines, while there are a lot of changes that could happen at the federal landscape that could impact models like the AHEAD model that we've been thinking about, we want to maintain openness to pursuing those models moving forward and to not create timelines that could in any way pit us against what we're already committed to, because that could potentially really send up a red flag to our federal partners and create havoc that was very much unintended. Any questions on our overall position or direction? Okay. So then, if you don't mind, we are going to move to section 8, because we have Will Dempsey here, who I'll let introduce himself, because we knew that this was going to be a hot topic of conversation, at least from the agency perspective, and then we can circle back to some earlier sessions.
Sure. Oh, okay, because we don't have this yet. We don't have it, so we can't follow up with you on this. We're gonna need it.
Thank you for telling me.
Yeah,
That's
so
great.
For the record, Will Dempsey, I am the health data officer for the Agency of Human Services. Good morning, Chair.
Welcome back.
Senators. Good to be back. Thanks for people. So, thank you for being flexible, letting us jump into section 8 first. So it's just one slide. I'll talk about through it, and then I'm happy to answer any all questions as we go, or at the end, whatever works for the chair. So I want to start with overall section 8. Directly, we are very happy with it. It's a big step forward, and it's very innovative. I broke this out by a few different parts within section 8 and just wanted to provide some specific feedback and point some things out to you all. The Agency of Human Services right now is really well positioned to collaborate with our Health Information Exchange Steering Committee. It's a long-standing, well-established, multifunctional group of payers, providers. There's a member of the public that sits on it. We have IT professionals, so it's a well-represented body. And we are always looking for new organizations to partner with and incorporate in that group. So the thought that we had was that could be a good collaboration point for AHS to ensure that we're touching a large variety of stakeholders rather than calling out specific entities within the bill. Moving down to section B, number 2, I believe that Beth Anderson, my CEO, testified on this yesterday a little bit. This one confuses a couple of concepts. And my personal recommendation would be that we remove this section to provide clarification, so it doesn't potentially overlap with work that the Vermont Health Information Exchange performs. Perfect. And we can provide more specifics if you would like, Senator. B4, this talks about security and privacy. It talks about best practices and standards. Our personal preference would be to focus on the standards. Those are usually federal standards, which are very strict, stringent, and a high bar. And we want to adhere to that. We're required to adhere to federal standards. So best practices just seemed a little bit of a lower bar than a standard.
Got it.
Moving down to B5. This language includes a reference to VCures, the systems.
First, I have a question about the standards, and you say
Please.
they're federal, and we see that changes are happening with really fast.
Yes, they are.
So, should we reference the standards currently in place, or that would offer improvement? I don't want to see the standards decline,
Mhm.
and then we're stuck. So, just a question.
I would leave it at, personally recommend that we leave it at standards because it gives us the greatest flexibility to adhere to what those standards are.
Okay,
And they are very rapidly evolving at the federal
Yeah.
level. So that's right.
word security.
No, leaving security and privacy
yeah, leave it.
Got
it. It just standards in instead of,
instead of best practices.
okay, thank you.
Any other questions?
Well, so yeah, just to push back a little bit. So if the standards do degrade, let's say, it is best practices a good alternative to sort of a degradation of federal guidelines.
Well, best practice point to the standards because the standards are the bar that's legally required.
Keep our fingers crossed.
You can always go beyond
Okay.
the standards.
Yes.
True. Okay. Seems good.
We can always be better.
Thank you, Caroline. So B5, this section talks about the linking of the clinical and claims data. It calls out VCures, the system that the Green Mountain Care Board has for the all payer claims database. Our recommendation on this is to make it about claims on a specific system. Because systems change, systems evolve, system names change, and we don't really want to link it to a specific system. And we also are going to be building off of, as I mentioned in my previous testimony, the Medicaid Data Warehouse and Analytics Solution called MDWAS. That's the foundation. So we just don't want to include system names specifically, but we do want to include claims, as well as the current references around social drivers of health, health-related social needs, and clinical data. And I wanted to point out, essentially, we want more data on more people.
Yes.
And
The bigger.
Put
the
that way, it's a little scary.
not trying to sound ominous,
I see Big Brother up there.
gives us a fuller picture on the health of the individuals in our population, the health of our population as a whole.
Right.
Yeah, it's very exciting. And then moving down to
Wait, we have a question here. Go ahead.
Jen Harvey, legislative council. So I do see in V5, we don't specifically say clinical data. Would it make sense to say determine how best to incorporate the clinical data, claim data, and data regarding social drivers of health?
yes,
Okay.
Good, that sounds good.
thank you.
Problem solved.
Right, procedure lines.
Go ahead.
Thank you. Moving down to B6, we have, this is the line about interoperability. And Beth Anderson yesterday talked a little bit about that interoperability from Vitals perspective, which is about connecting electronic health records. The interoperability that we should be referencing here is about different data sources across different systems. So it's not interoperability about electronic health records. So would recommend striking the electronic health records specific, and we can provide some specific language about systems and things like that that would broaden it because it's bigger than just electronic health records. It would include the Medicaid Management Information System. It would include things like our Money Follows the Person program. It includes bigger than just electronic health records. Okay. And then last but certainly not least, B10. This is a follow-on of additional ideas for the future. The thought that we had and is to leave that a bit broader rather than very specific. One of the projects that's listed is actually happening right now with WIC, with Infant Children. That is ongoing work that Vital is doing with the Department of Health.
So rather than specifying something, could we say such as, or is that not making sense?
We could provide some examples, but we could also be more broad and say opportunities for development in the future, including adding additional data sets to include larger populations and more data on populations.
Okay. All right,
Yeah, that should be in there.
okay.
So that's my slide. Any questions, Chair Lyon? Any comments?
Committee, go ahead.
Thank you, Madam Chair, Diane Blanford, Green Mountain Care Board. I would like to just say that this was the closely worked language agreed upon between both the Green Mountain Care Board staff and with AHS. So they worked this together and
Thank
we
you.
agree.
That's terrific. Terrific. Yes, thank you.
You're welcome.
Of course,
Okay.
thank you very much. Okay, I will hand it back over to Monica.
All right, good.
That's now step out.
And now we do have your information on our webpage. There we go.
Bring some musical chairs and having another one of my colleagues come in. Maybe.
That's what?
That's the one. Like a rabbit from a hat.
Okay.
Let's see.
Want to sit together? Yeah.
Switch
just bring your
forward.
chair up.
Monica, why don't we just walk please? Yeah.
So Monica, we still don't have your slides.
I just messaged, I phoned a friend. I'm so sorry about that. I think about you, I was sending them over, but.
Okay.
This one's right. Okay.
As long as we have them here, but ultimately we're gonna need them so that we can go, as we go through the bill, yeah, we need to refer.
Absolutely. All right, so thank you for allowing us some time to go through section 8. Could you like to introduce yourself to the record?
For the record, I'm Jenny Samuelson, the Secretary of the Agency of Human Services. Thank you for having me back. And good morning. I am Sarah Rosenblum. I'm the Deputy Director of Healthcare Reform at the Agency for Human Services. Thanks.
Heading back to section 1, back from the top. Again, sort of related to our original commentary when we started. We just wanted to make sure that in section 1, that as it relates to AHS authority over Medicaid, that Medicaid be stricken, as this is not within GMCB's authority. As it relates to reference-based pricing and rate setting, we wanted to clarify that reference-based pricing is specific in its context to hospitals, clarify that rate setting is specific to commercial rates for hospitals, and that reference-based pricing to be implemented no later than 2027, providing flexibility on timing and recognizing certainly that GMCB has resource limitations in achieving this.
Right.
Section 2. As it relates to reference-based pricing, we wanted to share some of our experience in reference-based pricing. We've been doing this in the Medicaid program for quite some time, and plan to move towards hospital global budgets in 2026. With reference-based pricing, you still run the risk of uncontrolled utilization in the absence of global budgets or some sort of cap. Yeah, so need to ensure that there won't be an increase in balanced billing practices as a result, where hospitals can seek payment directly from patients to offset lower insurance reimbursement. I think I heard some comments related to that this morning.
Yeah, right. But if I recall correctly, we also heard that utilization is an issue and provides access.
I think that there might be more to it than
I
that.
think it's an and where I would go with that, if I may, Senator, it's an and both. There are definitely areas where we see access related concerns. We are right now in a space in the Medicaid and the commercial space where we are seeing significant increases in utilization, which are driving the healthcare cost curve. And so we have an opportunity to dig into that further. I think it isn't, while it's complicated, it isn't and both. Primary care, dermatology, endocrinology, cardiology. There's a list of particular outpatient specialties where we definitely have long wait times and challenges getting in. And yet, over the last year, we have seen significant increases. And I think Blue Cross Blue Shield could speak to this as well as Medicaid, significant increases in utilization. What we don't want to do is to create a short-term scenario and situation in which we set up one system and then not look towards the long term. And so overall, what you'll hear us talking about here is general support of the bill, where it sets up reference-based pricing, which Medicaid's been doing for over a decade, and the experience of making sure in the longer term that we're looking at a global budget model. So that I think that credit to the committee and to the senator, this does that.
Okay, and the remaining bullets on this slide are about aligning. If we are moving forward with the head, taking care to align what's in the bill related to hospital global budgets, which with what's in the ahead state agreement. There's two elements there. One is a timing component. The ahead state agreement requires that we have some hospitals participate in the hospital global budget by 2027. And the other element of it is a methodology component. So the ahead state agreement references the percent of Medicare fee-for-service net patient revenue in Vermont that is associated with the hospital global budget. It doesn't tie us to a specific number of hospitals. So, you know, as this bill moves forward, if we are interested in doing ahead, I think it would be prudent to align the timing and the methodology of hospital global budget with what we've committed to with the ahead state agreement.
Okay.
And Sarah, if I may add, just so that folks are aware, it is out in the public sphere at this point. As we all know, the federal landscape has shifted significantly. We've been waiting to hear what their position is going to be on ahead. Yesterday, they did release that they would be continuing with the ahead model, but that there are going to be potential changes to that model. As everyone knows, they're at the federal level with the executive order. There's been significant scrutiny on the word equity. The E in the ahead model is equity, and they're using that as an opportunity to potentially open up our agreement. So Sarah was very cognizant to say, if we move forward, we still believe it is the right direction for our commercial insurers and for Medicaid, but we will need to evaluate what the impacts of the federal landscape. But we don't want to preclude the opportunity to participate if it still makes sense for Vermont.
And the word equity to us in this state has held multiple meanings.
Yes.
So economic equity is huge. And that's what
And furthermore, the model,
access.
we were surprised that they used equity in the model instead of transformation. Because to be honest, what this built into the head model around equity really is around transformation. It's evaluating the effectiveness and efficiency of our hospital systems, ensuring it aligns with our overall outcome measures that we are trying to, and drives change in our system towards what we have all established as the goals. That to me sounds a lot more like transformation than it actually does equity. And
G doesn't give you a nice.
it doesn't give you a good acronym. Exactly.
EAD doesn't really have a right.
But one of the values of the agency is transparency. And so I wanted to make sure that at the end of the day, that it didn't start to spread throughout, that this had been publicly posted yesterday, that it both will continue, but there are likely to be modifications. And if those modifications don't make this the right model for Vermont, because Vermont is already a low-cost Medicare state, we are going to have further conversations. Okay, moving on.
And closing up section 2, Jen will see this referenced in our markup. We recommended striking the section related to non-hospital services for the earlier.
Right, we just had a conversation about that, and we'll try to get to a place and look and see what it looks like.
Sure. Section 3, it's not really neutral in this section, and you have any additional comments to add.
We like it. We do that. budget review, and that's where we ended, so this is good. We'll have some.
I think in section 4, we were supportive of incorporating the commentary related to incentives and into the hospital budget proposals instead. We recognize that, global budgets to be implemented no later than 2028, and providing some flexibility on timing, recognizing again, resource limitations at the Green Mountain Care Board. And overall support greater flexibility, allowing GMCB to triage closures, service line reductions, and be thoughtful in how they're using their resources to make those considerations and review those changes. Recognizing probably all of them don't need the same degree and level of scrutiny, and support the exemption for closures and reductions made as part of work that we're doing in collaboration already. Section 5, generally neutral, no specific comments. Section 6.
Here we are.
So AHS is supportive of the concept of putting together a statewide plan, overall, in collaboration with Green Mountain Care Board and other partners. This work closely aligns with what we've been doing for the last several years. Overall, it's an opportunity to really bring together partners and organizations, and it's not necessarily limited to the way we've done the work for the last couple of years. We would ask that we make sure that the scope of this work reflects and is specific to reflect the areas that we really need to prioritize at this point in time. Hospitals, mental health, substance use, home health, skilled nursing facilities, emergency medical services, and primary care. Overall, what we have seen is the significant work to stabilize each of these sectors over the last couple of years. And they reflect significant changes where we see demographic changes. So what we want to do is learn from the all-payer model, which was, the conversation became about who was in and who was out, rather than actually getting down to the work. It also is reflective of the responsibilities in Act 51 of the transformation and the work that is in progress. So again, limiting it down to be more specific, we would also as we look at this, Agency of Human Service, again, if we'll support, willing to coordinate the collaboration across the partnerships and the groups, but we want to recognize that we can't do this alone. That the Green Mountain Care Board's expertise is really in the areas of hospital finance and overall in the hospital system and hospital payment methodologies. And so we want to ensure that this continues to be, while we're willing to coordinate, it continues to reflect the authorities that the Green Mountain Care Board has. Green Mountain Care Board also has authorities over insurers, as does DFR. And so we feel it's really important to bring those three regulatory entities to the table. We want to make sure that the scope of this, recognizing the amount of work, if we want the agency to continue the work that we've been partnering with the legislature on, particularly in the areas that we've defined. And we want the Green Mountain Care Board to carry out the heavy lift of reference-based pricing and global budgets over the next couple of years. We need to be realistic about what this plan would look like. We're recommending that it's a plan that would reflect 5-year set of priorities and that is updated on an annual basis, but that we have the flexibility over the next few years in how we develop it. That unlike, I don't think you all want to read a novel. It would take away the focus, and so the flexibility, so it is not simply a word processing document, but that we could present it to you in a more flexible way. For the timeline, We feel it's important that we continue to report out progress in each one of these areas over the next couple of years. And yet we believe that the timeline in it as written for 2029, as long as the administrative version of developing it is reasonable, sounds like it would work, but would want to report out the progress to you over the next few years in each of those areas. Return to my colleagues, see if I've missed anything.
No, thanks.
No, it's good. Senator Dolan, go ahead.
You may maybe say what I was going to say, but thank you for bringing up the collaboration piece. Absolutely so important. And I'm very much in favor of a lot of the testimony that we've heard that suggests that one particular agency should be in charge. And I'm a relatively new senator, but I've already seen a lot of reports done and work done that just doesn't quite, get into the meat of the substance because there was so much collaboration that no one was able to really guide the ship.
Right. Again, I think that's, I think we've heard a couple of times folks reference that, that this work, particularly as you've seen its breadth, crosses the Agency of Human Services, who already does significant planning in the majority of these areas, including mental health. So if there's a mental health 2030 plan, there's the healthcare sustainability plan that was written. There's a transformation planning. We do a significant body of this work, and yet we don't have the full expertise to do the hospital finance component. So we're willing to take a coordinating role, and yet we will need other partners to come in to fill in the gaps. And that's the challenge, because this is a very broad system. Does that senator get to?
It does. I thank you for the clarification. I appreciate that.
That's good.
Yeah, and as written, I think it does reflect the committee's understanding
Yes.
of that.
Oh, yeah. Yeah, no, thank you. Clear.
Section 7.
For section 7, we think it's important to include the Medicaid director on the advisory committee. In the agency, the reason being, in the Agency of Human Services, the Medicaid director on our executive team functions in a couple of different ways that folks should be aware of. The Medicaid director does oversee the Medicaid program, but they also are the primary contact over the Department for Health, Department for Mental Health, Department for Disabilities, Aging and Independent Living, the Department for Vermont Health Access. So they have a breadth of knowledge and experience that's not just Medicaid, but goes across the full functions of the areas that you've asked us to look at in this.
So the issue on this advisory committee has been membership. And so it's good to hear your recommendation. And so we'll have to sort out how this goes,
Right.
honestly.
In our experience, when we did the healthcare sustainability work coming out of the pandemic, we found that it was really important to focus the membership on the work that we were trying to achieve. And so if you're talking about the work here being focused on hospitals, mental health, and the co-occurring system of mental health and substance use, long-term care, including home health and skilled nursing facilities, the work with primary care and EMS services, that the membership should reflect the providers in those sections, which you've done a good job of in this section.
Okay. Makes sense.
Yeah, I no doubt you've had a lot of interest and participation, and in our opinion, keeping it small and agile is critically important in order to advance the work on a year-to-year basis.
I think we also wanted to discuss that the committee be co-chaired. Right now it's co-chaired by the chair of the GMCB and the director of healthcare reform. I think we would like it to be co-chaired by the secretary of AHS to provide some flexibility there. And then, or a designee. Exactly.
Oh, got it. Okay. That makes sense.
And for just for the benefit of this committee, there's some work that's happening already that feels very adjacent to this. And so we would see that as moving towards this versus having duplicative
Well,
efforts.
I see it as sort of the foundation for the plan. There's no question about it. The work that you are doing is just, is critical. No question.
Section 8, we covered, with Will. Section 9, we agree with the recommendation, to strike this section. But did want to flag that there is a considerable amount of work
Yeah,
happening with the agency and One Care Vermont in order to understand and appreciate the gaps that will be left, both in terms of operations, functions, data analytics, et cetera. And are conducting that analysis in partnership with One Care. And there's a lot to be gleaned from that, and would certainly recommend, if you want to understand more about that, we're happy to come in, but I think
yeah,
having
we
One
do.
Care come in.
That's
Yeah.
critically important to me personally, with it, not personally, but for this. And it would be helpful to have you come in. But my question would be, is it helpful at all to say that you'll continue your work on this? Is there some little one-liner that we can put in? Does that make sense? Or,
I don't think,
yeah,
I don't know that
Well-
it makes sense because we're doing it. So I think I would defer to.
I know, but it's
Yeah.
the point that you're doing it, but we don't know it. So if we have it here and it
Sure.
says you're doing it, then we might say, please come back and share with us what's going on. But because we do forget.
Yes,
Yeah.
we would be delighted to come back and share, because I think that it would be to the benefit of the
Okay.
committee to understand the gaps that are going to be left, and we're fully beginning to
Totally,
appreciate
and
this.
that's critically important in terms of the appropriations process.
Yeah.
So maybe we'll put something in there that's just like a little reminder of the work you're doing.
Absolutely.
Okay,
So if you short the section,
oh, yeah.
well, I mean, if we strike, that's getting rid of 7 sentences.
We'll sort it out.
It could
Yeah,
also be.
I mean, there's data involved, there's software involved, there's money involved, there's all of that. We know, we've heard there's $1 million sitting there somewhere. We don't, so what's,
Senator, might I recommend that this is a part of that overall plan that
Yeah.
you have put, that has put into this, and it may be that could be incorporated. Again, I think as we did this year on ahead, it makes sense for us to come into the healthcare resource committee
right,
in December and report out on progress. And so this could be something that could
put in there. That's a really good idea.
correct.
I like that.
So I, again, recommend striking it, but this is, as you think about the plan, this is a part of the consideration and planning that folks are doing at this point in time.
That makes sense to me.
And in closing, I think we would just like to say thank you for considering this. It's what we think about all day, every day. And wanted to say thank you to especially Green Mountain Care Board, and they're one of many partners, but we have spent a considerable amount of hours together in the past few weeks, going through this line by line, topic by topic, really trying to figure out how we can leverage each other's skills and expertise and area of content expertise in order to do this really well together.
Thank you for that. I know it's hard work, and it's been hard work for all of us, but we appreciate that on top of the life and the work that we have. Okay. Questions committee. Good. And we'll get it. Let me see if we have it. We haven't gotten it yet, but if you can make sure that we do get it, that would be cool.
Absolutely.
Thank you. Good. All right. We have a few minutes before 10:15, and given what we're doing, I'd like us to take a 5-minute break and come back before 10:15.